Compounding is a way of mixing or combining different medications and formulations that are not commonly available at most pharmacies. One of the major advantages of compounding is being able to treat patients with a simplified treatment regimen with multiple formulations being used in a single topical agent.
This is Dermatology Weekly, where we bring you interviews with leaders in the field of clinical and research dermatology, as well as what's new in dermatology. Welcome to episode 69 of Dermatology Weekly. It's a resident takeover episode featuring our residents, Dr. Daniel Mazori and Dr. Nadine Shabeeb, in a conversation about topical compounds. You can find their conversation following the news portion of this episode. And before we get to the news, a quick reminder that you can contact the show at podcasts@mdedge.com. You can find the email address in the show notes. You can also follow us on Twitter at mdedgederm. Okay, it's time for what's new in dermatology. We begin today with pilot study data on the treatment of severe recurrent canker sores. Apremilast was highly effective in treating patients with severe recurrent aphthostomatitis. The response was rapid and the treatment showed an excellent safety profile. This is according to results of a small study presented virtually at the 2020 annual meeting of the American Academy of Dermatology. The researchers noted that while there is no principal etiology for recurrent aphthostomatitis, immune upregulation plays a role in the pathogenesis of the condition. So let's take a look at the drug. Apremilast is a phosphodiesterase 4 inhibitor that downregulates inflammatory response by modulating expression of tumor necrosis factor alpha, interferon gamma, and interleukin 2, 12, 17, and 23. Apremilast is FDA approved for treating plaque psoriasis and psoriatic arthritis, and in 2019 the drug received FDA approval for the treatment of ulcers associated with Beckett's disease in adults. Now let's look at the study. It was conducted by Dr. Allison Bruce and her colleagues. Dr. Bruce is in the Department of Dermatology at the Mayo Clinic in Jacksonville, Florida. In the pilot study, researchers enrolled 15 patients with RAS to receive apremilast at 30 milligrams twice per day for 15 weeks after 1 week titration. To be eligible for the trial, patients must have had monthly oral ulcers in the preceding 6 months, at least 2 ulcers in the previous 4 weeks prior to enrollment, and at least 3 ulcers during flares, inadequate control with topical therapy, and no evidence of systemic disease. The researchers excluded patients on immune-modulating therapy, systemic steroids, pregnant or breastfeeding women, those with a systemic infection, those with a history of recurrent bacterial, viral, fungal, or mycobacterial infection, those with a history of depression, as well as those with a known malignancy or vitamin deficiency. Patients were assessed monthly, evaluating number of ulcers, visual analog pain scale, physician's global assessment, and chronic oral mucosal disease questionnaire. The researchers report that within 4 weeks of therapy, complete clearance of RAS lesions occurred in all patients except one, and in that patient, ulcers were reported to be less severe. That patient did have considerable reduction in the number, size, and duration of oral ulcers. Remission in all patients was sustained during 16 weeks of treatment. Questionnaire responses improved considerably from baseline to week 8, and that improvement was continued until week 16. The most common adverse events were nausea and vomiting and headache, but they were mild and tolerable and generally resolved by the 4th week. The researchers acknowledged limitations in the study, like the small sample size. They also noted that one considerable challenge moving forward would be insurance coverage. We move now to African Americans and access to a dermatologist. In research presented virtually at AAD 2020, investigators report that urban zip codes that have higher percentages of African American people living in them tend to have fewer dermatologists. And in these areas, dermatologists are not able to meet the needs of the population. In the study, researchers at the University of Michigan's Department of Dermatology drew from the 2010 U.S. Census to identify zip codes and populations of 25,000 people or greater, because these population centers ought to have at least one dermatologist. Next, the researchers ordered these zip codes from low to high concentrations of African American people. Those that fell in the 15th percentile or fewer were categorized as low. There were 370 such zip codes. And those that fell in the 85th percentile or higher were categorized as high. A total of 443 zip codes fell into the high group. Following this, researchers used the Definitive Healthcare Provider Database to identify the number of dermatologists practicing within each zip code and to calculate the average number of people per dermatologist in the low and high categories. The researchers found that zip codes that have a high percentage of African American people living in them have an average of just over one dermatologist in those zip codes. That's about one derm per 40,000 people. That ratio falls well below the recommended limit of about 1 per 25,000 people that we referenced earlier. Meanwhile, zip codes with a low percentage of African American people averaged more than 2.8 dermatologists living in them. That's about 1 per 14,000, which is well above the recommended ratio. These data suggest that the distribution of dermatologists is not uniform, even within the urban environment. This is especially true when compared with the areas that have different representation of African Americans. And finally today, one subtype of melanoma is on the rise in a specific patient subgroup. The national incidence of vulvar melanoma is on the rise among women who are older than 60. The average climbed about 2.2% per year in the period between 2000 and 2016. This is according to data that was also presented virtually at the annual meeting of the Academy of Dermatology. Vulvar melanomas are often aggressive. Indeed, the 5-year survival following a diagnosis of vulvar melanoma in women 60 years or older was just under 40%. This is compared with a 5-year survival of about 62% for a similar diagnosis among younger patients. In the study, researchers analyzed data from the NCI's SEER database and found that vulvar melanoma was rare during the 16 years of the study, with an overall incidence rate of about 0.1 per 100,000 women. That worked out to 746 analyzable cases. Notably, the incidence rate ratio was 680% higher in women who were 60 years old or older. One reason for the markedly worse 5-year survival in older women was that the predominant histologic subtype of vulvar melanoma in that population was nodular melanoma, which accounted for 48% of the cases where histologic subtype was specified. In contrast, the less aggressive superficial spreading melanoma subtype prevailed in patients who were younger than 60 years. That accounted for about 63% of cases. In the presentation, researchers noted that the vulva is the most common site for gynecological tract melanomas, accounting for 70% of them. And while the female genitalia make up only about 1 to 2% of the body surface area, it is the anatomic site for up to 7% of all melanomas among women. And that concludes the news portion for episode 69 of Dermatology Weekly. Coming up next, the residents are taking over. Welcome back to Dermatology Weekly. It's time now for our residents to take over the show. Please welcome Dr. Daniel Mazori and Dr. Nadine Shabeeb.
Today I'm talking to Cutis resident corner columnist Dr. Nadine Shabeeb about her latest column on compounding in dermatology. Dr. Shabeeb is a dermatology resident at the University of Wisconsin in Madison. Thank you so much for joining me today, Dr. Shabeeb.
Thank you for having me.
So I wanted to start off by talking about exactly what compounding is, especially for our listeners who may not be familiar with it.
Compounding is a way of mixing or combining different medications and formulations that are not commonly available at most pharmacies.
What are some of the potential advantages of compounding?
One of the major advantages of compounding is being able to treat patients with a simplified treatment regimen with multiple formulations being used in a single topical agent. Another advantage of compounding is that it's a way to prescribe treatments for rare conditions that aren't commonly available. One example of this is topical sodium thiosulfate to treat calcinosis cutis, as intralesional sodium thiosulfate can be really painful for patients. Compounding can also be a way to bypass any issues with insurance or prior authorizations or uncertainty for how much a copay will be. And finally, another advantage potentially of compounding is that it can be a way to create a topical version of an oral medication.
That's really interesting. I think also when people think about compounding, one of the hypothetical safety benefits of compounding a topical formulation of an oral medication is to avoid systemic side effects. And so I wanted to ask if that is really the case.
So I think that can depend on how intact the skin is and also the strength of the medication that's used. For example, there was a case series of a couple of patients who used amitriptyline cream at 5 and 10% in order to treat neuropathic pain. And the patient who used the 10% cream had drowsiness that was severe enough that they stopped the treatment. So it can depend on how intact the skin is and then also how strong the formulation is for the medication.
On the more extreme end of the spectrum, have there been any reports of death from topical compounded medication?
So there were 2 deaths that were reported with applying compounded topical lidocaine and tetracaine gel, and that was due to systemic absorption. And in that case, the gel was used before laser hair removal, so it was applied to greater than 50% of the body surface area and also under occlusion, which ultimately led to a fatal systemic absorption.
In addition to the possibility of systemic absorption, are there other potential disadvantages of compounding that we should be counseling our patients about?
2 of the major disadvantages about compounding is that there's often a lack of published data about the safety of compounded medications, as shown in the example that we just talked about, and then also about the efficacy of compounded medications. Another possible disadvantage is the cost.
What is it specifically about compounded medications that make them lack safety and efficacy data, especially because presumably they're all based on medications that individually have that data available?
This is usually because of the unique nature of what's being compounded, because multiple different things are oftentimes combined together. So there's no published data about how safe and also how efficacious these are compared to just one single formulation being used. And while there might be data published about the efficacy of an oral medication, this doesn't necessarily translate to the topical form also being efficacious. And a lot of what's published in the literature about compounded topicals is limited to case reports and case series.
I agree that's important to consider. You had also mentioned that cost could be a potential disadvantage. So I wanted to ask you a bit about that, especially because earlier we talked about how one of the potential advantages of compounding is that it can allow the patient to bypass insurance and uncertainty with copays. But I guess there's a caveat with that.
Yeah, so medications that are compounded aren't covered by insurance. So the out-of-pocket cost may be prohibitive for some patients. That being said, it may be lower than the cost of a branded medication that's not covered by insurance, but it may be more than a generic medication that is covered by insurance. And usually compounding pharmacies will contact patients first and give them a price estimate.
Since we talked about the lack of safety data, I'm curious what regulations compounding pharmacies are required to meet.
Compounding pharmacies have to follow safety standards that are set by the U.S. Pharmacopoeia. The FDA also says that physicians can't prescribe compounded medicines that are unapproved, adulterated, or misbranded drugs. And that last point has been interpreted to mean that compounded medications can't mimic a branded medication. It has to be either a unique formulation or combination or strength.
Since you wrote a column about compounding, I imagine that you've had some experience with it as a dermatology resident. So I wanted to delve into that just a bit. What compounded topicals have you prescribed and for what conditions?
For the medications that I've compounded thus far during residency, it's not really evidence-based, but it's based largely off of case reports, case series, and also from the positive experiences of attendings in my department. One combination that we use often is calcipotriene and 5-fluorouracil compounded together to treat actinic keratoses. Amitriptyline and ketamine can also be compounded together to treat neuropathic pain or neurodermatitis. And 5-fluorouracil and salicylic acid can be combined in order to treat warts.
I've also heard that compounding can be popular for conditions like acne, rosacea, and hyperpigmentation. Do you have any experience compounding for those conditions?
Yeah, so what's cool about compounding for those conditions is that there are oftentimes multiple etiologies that lead to patients developing those conditions. And with compounding, you can mix multiple things together to target some of those different factors. So for acne, I've compounded tretinoin, niacinamide, and azelaic acid together. I've compounded for rosacea, metronidazole, ivermectin, and azelaic acid together. And for hyperpigmentation, I've compounded hydroquinone, hydrocortisone, or a stronger topical steroid, and tretinoin together.
Based on your experience, I was wondering if you had any practical tips for dermatologists when it comes to compounding, especially those who may not have done it before and would be approaching it for the first time.
So most major cities have either apothecaries or custom compounding pharmacies, and I can't stress enough how helpful their pharmacists are. So when you speak directly with the pharmacist, you can tell them about your patient's diagnosis and their specific needs, and they can really help guide you through which formulations to compound, which strengths to choose, and which strengths they have most commonly compounded with in the past, and also the best vehicle to use as a base. There are also online compounding pharmacies available, but I have not had any personal experience with those.
That's awesome to hear about how helpful a compounding pharmacist can be. Can you think of any examples of a time when a compounding pharmacist helped you out?
So going back to my example of when I had compounded topical sodium thiosulfate to treat calcinosis cutis, I called our local compounding pharmacist with kind of a general idea based on case reports. And he ultimately told me the appropriate concentration, which vehicle to use, and really helped make my idea into a medication for the patient.
I think that's an awesome example because it shows how a dermatologist can have a vague idea of something that they want to create, but not necessarily know the right strength or vehicle to actually materialize it into something. So to be able to have a resource like a local compounding pharmacist to have that conversation with and turn ideas into reality is really cool. So I hope that our listeners find that inspirational for any of them who are curious about compounding or have had thoughts about things that they would want to compound, but didn't necessarily know how they could do that. So Dr. Shabeeb, thank you again for sharing your experiences with us, and to everyone, happy compounding.
And that's all for episode 69 of Dermatology Weekly. Derm Weekly is produced by MD Edge Dermatology editors Melissa Sears and Elizabeth Meshkati. Peer-to-Peer is produced by Melissa Sears and Tyler Mundek. The news portion of our show is produced by Elizabeth Meshkati and written by myself. Stories this week were originally published online at MD Edge Dermatology and written by Doug Brunk and Bruce Jansen. All MD Edge podcasts are produced by Medscape Vice President Dr. Ivan Aransky, as well as MD Edge executive editors Kathy Skarbeck and Mary Ellen Schneider. And our social media is produced by Kyla Clark. The notes are written by Melissa Sears and copy edited by Carol Nicoletta Ward. The show is engineered, edited, and mixed by Tyler Mundek. I'm the voice of MD Edge Podcasts and the host of Derm Weekly News, Nick Andrews. You're listening to Dermatology Weekly.